Well, it's a pleasure and an honor to see everybody at this regular occurrence. I'm so sad that we're not face-to-face, live in Chicago, but I'm glad that we're able to continue the important business of running the SLAI. Our biggest news, I think, is not a big secret to any of you. Dr. Alejandro Mojar had a governmental-based conflict with executing his duties and had to step down as our international executive officer with a special attention toward the SLAI program. Dr. Mojar accomplished so much that I could probably take the rest of this meeting listing all of it, but I'll simply say that he advanced our efforts in Latin America so substantially that I will be forever grateful. I'm equally pleased that while we haven't found, I don't want to use the word replacement, we have found somebody to fill that role, if you will, who I think is equally skilled, equally well-known, and I'm sure will do a spectacular job. I was so happy and pleased that Dr. Mariana Chavez-McGregor from MD Anderson agreed, as busy as she is with ASCO, as busy as she is with the Hope Foundation, to oversee our entire international program, again, with a special focus and effort on Latin America. She is a true go-getter. We just this morning set up a series of regular meetings, which is something that I haven't done actually with her predecessor or any of my other executive officers, and I'm pleased to have this opportunity. We're going to make sure that our Latin America program stays on track and expands beyond where it currently is. So that is it for my introductory remarks. I hope the rest of the meeting is wonderful for all of you, and I will turn it over. Thank you. Thank you so much for attending this meeting.
Well, thank you. Thank you for your kind words. And of course, welcome everyone. Bienvenidos todos. Muchas gracias por acompañarnos. First of all, I really want to thank Dr. Blanqui for this opportunity. Clearly, there'll be challenges, but I believe in all the great work that we can do with the Latin America initiative. Of course, I want to recognize the effort and the hard work of Dr. Alejandro Mojar and his continuous support. As the new executive officer for international affairs, I'm really hoping to continue to engage and to really integrate our international, particularly our Latin American investigators, into our disease-specific committees and continue collaboration. I think as we start, there's some very special shout outs that I would like to share with you and people that deserve true recognition. Uruguay and Brazil are now official members, so welcome. They got their State Department approval just about 10 days ago, so we're super excited about all the opportunities. As Dr. Blanqui announced in the plenary session yesterday, the National Cancer Institute in Mexico, or INCAN as we know it, was recognized as a top accruer, and Dr. Javier Retamales from Chile was selected last year, but will participate this year in the SWOG Young Investigator Award. So thank you so much, and clearly a lot of talent from our colleagues in Latin America. I want to start with a big thanks to Courtney Wiley for her help in the planning the entire meeting. The entire slide team, including, of course, Dr. John Crowley, Rachel Sexton, Cord Mallory over at CRAB, they've been incredibly helpful. All of you know Dasha Kristen. She is just outstanding, and Dasha, we couldn't have done any of this without you, so thank you. Thank you, of course, to the Hope Foundation for their support, and to all the many people in SWOG that believe and have support and work for the success of this initiative. As you can see, we have a really packed and very interesting agenda. We're going to try to talk about the overview of the cancer situation in Latin America, discuss opportunities there, and then get to hear about different investigators from Latin America in terms of ideas that they have. So without further ado, we're going to start with Dr. Marion Piniones. She joins us from France. So thank you so much. She works at the International Agency for Research on Cancer, and she specifically works for the Regional Hub for Cancer Registration in Latin America. So Dr. Piniones, thank you so much.
Thank you very much for the invitation to to the organizers, and I will try to do in this short time a very, very brief overview of the cancer burden and patterns in Latin America. So the content, very briefly, I will highlight some relevant elements of the context, then show the major features of burden of cancer and patterns in the region, and then very briefly deal with some challenges, specifically in the cancer burden information that we are dealing with. So the first striking and important fact is the growth of the population. You can see that from 1970 to 2020, the population more than doubled. And this comes along with an aging population that the region will need to face not only the number of cancer cases that will grow, but also how to care for older population, because this is what's coming up in 2040. Together with this, we are the region, I say we because I'm Colombian, the region with most urbanization. The population lives in big cities. Almost 82% of the population nowadays lives in mega cities. And obviously this comes with facing imbalances. Inequalities is one of the sad news, or not news, but one of the sad factors in the region. And a perfect ground for a perfect storm when COVID came. So we have the region of the Americas with the highest number of deaths in all the world, which is also in terms of the rates. And you know very well all the protests that we still don't see all the impact that they will have in terms of health and in terms of cancer care. So with this background, here we can see the most frequent cancers, the top 5 cancers in the world, and in the 3 subregions of Latin America, South America, Central America, and the Caribbean. They all share 3 top cancers. Prostate, breast, and colorectal are nowadays the most important cancers in the region. Lung and stomach in incidence also for the Caribbean and South America. Central America has a little slightly different profile in incidence, with cervix as a 4th place and then stomach. And in mortality, more or less the same cancers, but Central America differs slightly, with liver and stomach in the first 2 places. So I will highlight and show some of the 3 main cancers, prostate and breast. Here we see prostate cancer incidence in blue, mortality in red, and very clearly how the Caribbean countries are the ones that have the highest rates, possibly associated with the African ancestry of the population. And here for comparison, I show in all the graphs the US rates. So you can see that for many of the countries, the rates in incidence are higher. And the rates in mortality for some of the Caribbean countries are the highest in the world. Let's see, Barbados, Trinidad, Tobago have really, really high rates, which merit further investigation, because I don't think it can be only attributable to the African ancestry. For breast cancer, we have similarly highest rates in those countries of Caribbean, but also Argentina, Uruguay, and Brazil among the countries with the highest rates. And mortality rates that are really above, for example, if you compare with the US that has a mortality rate of 12.4, most of the countries are above, with incidence rates that are below. So this really speaks about the prognosis of female breast cancer in the region. What have been the trends? And I'm showing only trends in mortality because the incidence trends we have in-house are slightly old, and we are expecting the new data to come in. And we can see very clearly how for all of the countries except Cuba, for which we have these trends in the last 15 years, mortality of prostate cancer has come down importantly. Still rates are much higher. Here for comparison, the US rates. How about female breast cancer? We see that we have different patterns. Here is US for comparison, and we see that countries like Brazil, Colombia Mexico, Ecuador have increasing mortality rates, which might still be an influence of the growing incidence, and for Argentina, a decrease. What about colorectal cancer incidence and mortality? We see that the profile is more or less the same, with rates that are obviously or are higher among males than among females. And in the countries that have the highest rates, we have, for example, Uruguay, Argentina, but also, again, Caribbean countries with very high rates. Uruguay and Argentina, both in females and males. And we see that Argentina and we know that Argentina and Uruguay are one of the, if not the highest meat consumers in the world, something that could be very related, as well as the growing obesity, especially in Caribbean countries. And the rates for colorectal, both for male and females, we show growing mortality rates trends for most of the countries. In contrast, colorectal in the US goes down, colorectal mortality, and here for females, the same pattern. And just to show you too the behavior of the mortality rates and trends in two of the infectious related cancers that are stomach and cervical cancer mortality. As we know, for all countries, or for most countries in the world, the stomach cancer rates go down. I show only males here. All of the countries it goes down. But still, if we compare with US or other, we have still very high rates in countries like Chile, Costa Rica, Colombia, and Ecuador. For cervix, the rates, and we show them in this graph, the mortality rates only for women 0.49, because we didn't want to confuse the uterus unspecified. We see that the rates have declined importantly, but among young women in Argentina and Uruguay and Chile, we see that the mortality rates are increasing, and this also merits further investigation. Here, for comparison, the rates of the US and Spain. What is the projected cancer incidence burden by subregion 2020-2040? So in the next 20 years, we will see an increase of about 67% in the number of new cases, which is more pronounced for Central America, which paradoxically is less prepared. So this will bring also many challenges, especially because, as we mentioned, it will be older population. And then to finalize, I just wanted to highlight the big challenges we have with information, because the estimates that you saw are estimates based on different models, but for most of the countries in our region, it is based on mortality with some combination of incidence. But if we see only 8% of the population in Latin America is covered by high quality population-based cancer registry. So here we have an enormous challenge to improve the quality of those that exist, but also to improve the coverage and set up new population-based cancer registries. Stage information in the region, and we really need stage information, is scarce. We did some survey 2019, and we saw among 56 population-based cancer registries out of 89 that they answered more or less 60% answered that they were collecting stage for breast, cervix, colorectal, and prostate cancer, importantly. But if we look at the reports, stage is missing in all registry reports, except, for example, Quito Cancer Registry report has stage because they really have focused on having this information. And this, I think, is something critical, especially for many of you that are clinicians, and it's like the information that we would like to see much more on a population-based level. But
1 minute remaining.
And to show you the problem, for example, Bucaramanga, high quality registry, missing information on breast low thickness in melanoma cases, 58% of missing information. So as closing remark, the profile of cancer is changing. The leading cancers are now linked to Westernization. Still, infectious related cancer are important. The increasing mortality trends for breast and colorectal cancer are worrying. The social context is complex, and we have scarce population-based information and quality of that information. So with this, I leave you with our slide of the Global Initiative for Cancer Registry Development. Thank you very much for the attention, and the challenges for all are big and important in this region. Thank you very much.
Thank you so much, Dr. Piniones, for your presentation. I think we have 1 or 2 minutes for questions. I don't know if anybody in the audience has any question. Feel free to unmute your mic. Well, if we don't have, yeah, sure, go ahead.
One quick question, Marion. We know that one of the big deficits is budget restrictions in Latin America, and so I would just want to give for just setting up cancer registries and as well for clinical research. In your experience in looking at the whole Latin America, what could be a way or an answer to get some additional financial support? Should we have to go only for international financial support, or what's the expectations that you have seen, not worldwide, but in Latin American region in terms of budget support for cancer registries and particularly for clinical research? Thank you, Marion.
Okay, so I think that one important thing is to convince governments that we need to do surveillance. I mean, population-based cancer registries are surveillance. So governments set up COVID surveillance, but they don't look at cancer, and cancer will really affect. That is one thing. The other is a strategy that has been very, or I don't know if very, but that was successful in Colombia, is having always linked the universities, because that can give some stability and also academic research associated to the registry that at the end, you see that improves the quality. So the more research we do associated with the registries, the better quality we will have. And universities are a key player for this. Not only leaving everything to governments, but calling in on universities.
Thank you, Marion.
I also wanted to ask a question, if I may. So, is there a correlation between the incidence of breast cancer and the mammographic screening? Because it looked like that the incidence rate was still lower than in the US or in the West, but it was hugely variable across countries. And of course, we learned this, that as the mammographic screening uptake increases, then of course the incidence of breast cancer increases as well.
Yes, unfortunately, we can show this like ecological, because we don't have the information of screening uptake in the different countries. There is no such information in the countries because the screening programs, most of them are not centralized and with that follow-up information. So we could just gather probably some information for those countries that do some surveys and have information on the coverage, but not that we can link this with the incidence necessarily. But in any case, the mortality incidence ratios are not very well. I mean, that means that we still have a big challenge in terms of treatment and of effectivity of the treatment. Yeah.
Thank you.
We unfortunately don't have time for more questions. We're going to go ahead with our next speaker, Dr. Paula Cabrera, who throughout the years I had the privilege to call also my friend. She is a breast medical oncologist by training, but she currently serves as the head of the Medical Oncology Division at the National Cancer Institute in Mexico, and she's the SWOG PI in Mexico. She's going to talk about research opportunities in Latin America. Dr. Cabrera, thank you.
Thank you very much. Good afternoon to everyone, and it's my pleasure to be here, and thank you very much for the invitation. I am a little bit nervous. So as already mentioned, let me start with the more data. Cancer burden is increasing in low and middle income countries. It expects that 2/3 of the deaths from cancer in the next 20 years will happen in developing nations. Nevertheless, in the United States, there has been an improvement in most of cancer in survival. So as a low middle income countries, we need to face this challenge, and clinical research should be our priority to face this challenge. Numbers matter, and clinical research is changing. According to clinical trials, the number of oncology trials has been increased 1.6 times, at least in the 6 years. But in the USA, it has a decrease of 7% in 2021 compared with 2015. If we look at China and Europe, we see an improvement in the numbers of clinical trials of 7%. So in my opinion, LATAM could add to USA an additional 4% of clinical trials. Someone could argue that we have already a lot of evidence for most of cancer types. So why do we need clinical trials in Latin America? Well, let's see. Where are the patients? That's the question. LATAM can increase recruitment. According to GloboCan in 2020, Asia represents 49% of all of new cancer cases in the world. Europe has the second place with 22%. And despite our population registry, together Latin America and North America account almost 20%. And this number represents a huge field of research opportunities. On the other hand, and sorry, I have a trouble with this, okay. On the other hand, we follow leading money. And if we talk about pharmaceutical sponsored trial, you see in the top panel in red that most of the trials are taking place in Eastern and Western Europe. On the other hand, academic trials in the bottom of blue are mainly conducted in the USA, Canada, Scandinavian countries, and Central Europe. Let's have a look to the global rating markers in the left table. As you see, in 2020, despite the COVID crisis, the projections suggest that in China, Brazil, India, and Mexico, I hope so, we'll spend more money in medicine. And as you see in France, Spain, Canada, and UK, will reduce their spending. So these two factors combined could be a great opportunity to increase our clinical research relationships. Because, as it was mentioned and it was presented in ESMO by Dr. Joseph Unger, the NCT and randomized trials have generated substantial gains, leading in new standards of care of various treatments of our patients all around the world. So this is a very important issue. And the real world evidence, as you know, could optimize clinical trials, understand the disease landscape, help understand and archive approval from payers. And also, these type of studies are already being required by some regulatory agencies for approval drugs. So this is to the types and cancer care delivery research could also be performed in Latin America. We need to remember, as it was in the presentation before, our epidemiology, and unfortunately, almost 70% of our cancer patients are diagnosed with advanced disease and are at a younger age, almost not forever, but the cold tissue is the issue, continues a matter in 21st century. And maybe the new phrase will be tissue and blood are the issues. So LATAM could contribute to translational research also. Quality care. In addition, Latin America participation in clinical trials will be the key to increase diversity. Clinical trials participation and delivery of high quality care is key to reduce disparities. And it's important to do it, but it's also the right thing to do it. So we should remember that Latinos represent 80% of US population and is the fastest growing minority groups in the USA. So I know there are many challenges and many barriers, but also there are many opportunities. So we believe we can do it together. I hope so. In the time. Thank you so much.
Thank you so much, Dr. Cabrera, for that great overview. We unfortunately don't have time for questions, so we're going to move to the part 2 of our symposium, where we're going to ask the investigators from different countries to give us a very quick overview of their research efforts as they relate to SWOG and to SLAE. We're going to start with Dr. Javier Retamales, who joins us from Chile. He's the director of the Chilean Cooperative Oncology Research Group. Dr. Retamales, thank you so much for joining us. And I see him there. He was actually in clinic when he joined earlier. Maybe we will, since we have Dr. Retamales, there you are. If you want to share your slides, and you're on mute.
Yeah, okay. I can share it with you. I thought you were going to, as I sent that previously to Deisha, I thought she was going to show them, but
I can share them.
Sure,
I can share them if you'd like me to.
Yeah, can you share? They're
let me
just they're just 2 slides.
Sure, let me see Chile. And
so, hi everyone, I'm Javier from Gochi, from Chile. For all of you that you don't know us, we are our NGO, a non-governmental organization that built a network in a lot of sites in Chile. Because in Chile there are not a very big center of cancer, and a lot of the treatments sometimes are given in different centers. So for us to participate in network, we've been participating in a cooperative way since 1998. So that's the way we work. That's the way we have been working for a very long time. And in SWOG, in the SWOG Latin American Initiative, we try to make the same kind of work, activating different sites, not only the National Cancer Institute of Chile, but also other sites. So Gochi works as a coordinating center with the head CRA, Zdenka Slatar, and Darío Cuevas, who is in charge of contracts. And the sites, we have opened Instituto Nacional del Cáncer. The leader of the SWOG Latin American Initiative in Chile is Dr. Bettina Miller. And the investigators in the roster of the INC, Instituto Nacional del Cáncer, are Ingiborg Araya, who is a medical oncologist. She's been leading the S1714 study, and she's been very active enrolling patients, me, myself. And now we are submitting 2 additional investigators for other studies. Dr. Felipe Carvajal, who is a radiation oncology, very interested in lung. So we hope we can open the trials that I'm going to show in the next slide. Wait, can we go to the previous slide? Yeah. And Dr. Ann Walton, who is an urology oncologist for the urology trials. We also opened the Hospital Sotero del Rio, that I'm participating as investigator in that site, and we are submitting the another researcher from that center, Dr. Maria Victoria Perez, who is the gynecologic oncology, and we hope we can be we're going to open FALP, the Fundación Arturo López Pérez, soon, with Dr. Marcela Berrios in that center as leading oncologist of that site. The next slide, please.
Sorry, it's there. Whoop. Let me go back. You have, you have about 30 seconds remaining.
Yeah. So for the trials, we have S1714 active in Instituto Nacional de Cáncer, 9 patients enrolled, and we hope we're going to open that study in Hospital del Río. For the studies S1802, S1827, and S1914 that are radiotherapy trials, 2 from lung and 1 from prostate. We are in process of credentialing. I'm going to be sincere with you. We started the credentialing process in June of this year, and it has been very difficult for us to do the credentialing because a lot of different issues, including the importation of the Phantom, and now the IROC group confirmed that they have all the images for the IGRT commissioning, because the technique of the radiotherapy and the imaging of the radiotherapy are commissioning in separate ways, and they confirmed to us that they got the images, but they cannot load them. They don't know why. But
we're at time.
Yeah.
If you can just wrap up.
Yeah. So it's just 3 weeks of the other trials. For S1501, we are credentialing. We will submit the images maybe this month or the next month. For TIMIST, we need a local agreement with FALC for the tomosynthesis because that study need a lot of credentialing. And for SLA1, we want to participate, but we need the budget for that.
Thank you so much, Dr. Retamales. Next, we have Dr. Maria Teresa Vallejo from Colombia. She's going to give us the updates for Colombia. She's an epidemiologist and investigator in clinical research group at the NCI in Colombia, and she's the PI too. Do we have Dr. Vallejo?
Yes.
Yes.
Let me share the presentation. Can you confirm me if you see it?
Yes, and we just have 3-4 minutes, Dr. Vallejo,
Okay.
if you don't mind.
Okay, thank you. I'm talking in presentation of the Instituto Nacional de Cancerología in Bogotá, Colombia. Our SWOG team is a little big, and we expect to increase the amount of researchers. We have researchers in the fields of the clinical attention, as well as we have researchers from the clinical research and public health area, because the nature of the Instituto Nacional de Cancerología includes the developing of policies for cancer care in Colombia, as well as the clinical attention of cancer patients. In summary, we have studies with ethical committee approval that are ongoing. We have 2 that are already closed. That is the S1316, that is with malignant obstruction, and we recruited 1 patient. The study stopped, that was related with tobacco cessation, that the results are already published in literature, and that in our nursery oncology group participate. Also, we have the study S1007 about oncotype, and we are in currently follow-up. We recruited 10 patients, and we have active the study S1714. At this moment, we have 11 patients. We had some issues with the amendments that have published. We expect that in the next weeks, we can open again one of the branch that were closed because they completed the sample size. That will continue. We have champions from the unit of gastroenterology, from oncology nursery, and clinical oncology. There are Dr. Sanchez and Dr. Velasquez. Dr. Velasquez works as well and my co-PI. There are some other studies that are approved by the ethical committee, and also we have approval by the national regulatory agency. Some trials that includes medicaments must be approved by the national regulatory agency, that is INVIMA, that is our FDA. We have expecting the site activation. There's 1802 that is prostate cancer. There's impact study that is from York, and the Maverick study for lung cancer. We have two urologists, Dr. Carrera, Dr. Varela, and another clinical oncologist, that is Dr. Bujes, as champions of those studies. For these studies, we have the main issue about the AREC certification because we have issues to import phantoms and to fulfill all the requirements for all the techniques, IGRT, SBRT. We are trying to do everything sequentially. We are trying to work as a network, trying to collaborate how to solve these issues to import phantoms, and maybe in the future we could be more expedite to solve these requirements to open more efficiently these studies. We expect to solve these requirements and open recruitment between December 2021 or January 2022.
1 minute remaining.
Oh, sorry, I'm trying to finish. And the other one that is carvedilol, that is now in evaluation by our national regulatory agency. We have three studies that are not activated on SWOG, so we cannot fulfill all the criteria if we have to have their activations. And there are 4 studies that we are evaluating the feasibility. Perhaps the most interesting that we are wanted to work and more challenging for us will be the study TMIST for mammography, because we need to increase the associates to recruit people, because there are people without cancer. So we expect to develop new skills as a center to create more collaborative a network in the country to try to recruit these people. Finally, we have developed some regional studies. That is a cohort study in cervical cancer. That the PI is Dr. Juan Carlos Velázquez, that included patients with cervix cancer from Peru, Mexico, and Colombia, and it's finishing the recruiting.
We're at time.
Oh, thank you. So
thank you so much, Dr. Vallejo. Next is going to be Dr. Cabrera, giving us an update of the efforts in Mexico.
Yes, let me, here is the presentation. I hope everyone can see it. Oh, sorry. Well, in obviously of the time, I would like to say that since this story began, we have, we have increased the office. The amount of people that is working over there used to be only Dr. Mora and Dr. Aguilar, and up to date we have champions leader in the file of breast cancer research, lung cancer, kidney cancer, prostate cancer, gynecologic cancer, and palliative care cancer and epidemiologic cancer. So all of these, Dr. Sorry not to mention in overall the time, but I'll get right now in the office of the SWOG team of NCI. Also, this is our work. We, at the history, we begin to the non-small cell cancer. We could include 2 patients only. And after that, we developed the S0702 of osteonecrosis in cancer with patients with bone metastases, with 50-70%, 70 patients included. And after that, we made a great effort in responders trial, and we look to include almost 100 patients that are in follow-up. After that, beginning, well, not in the COVID time, but 1 year before, Dr. Krause has a very huge effort and mentor for us in the malignant bowel obstruction. We could include 8 patients. After that, we are very, we have a very good recruitment with the S7014 that, as you know, is a predicted model of peripheral neuropathy, and 60 patients has been included. despite COVID crisis. Prostate cancer, as my colleagues mentioned before, we have already to start recruitment, but as far as I know, there is a pending inclusion of international sites on protocol. Lung cancer 1827 is in approval process, and fortunately, we have a new champion for the biomarker gastric cancer, and hopefully is going to be open in this 2021. Next studies to active, the S2013, we are very interested in do this, as I mentioned before in my talk. It's kind of real world evidence that it's going to be very interesting to know. And also we had been invited by Dr. Henry to work in the young women with breast cancer. And we are trying to do our best efforts in the midst. There is a screening time schedule. Also, we
1
developed
minute remaining
this year. Thank you. We developed this year the clinical trials training course. We have 315 participants, mostly oncology specialists. I think this is important to mention, from Mexico, most of them surgeries, radiotherapy, medical oncologists, and obvious fellows. The median age was 13 years old, and we have also the participation of LATAM, like Chile, Colombia, and Uruguay. Finally, but not least, sorry, this is kind of a complicated issue, but the impact for our institution, the impact of has been SWOG partners. We had best performance, our clinical practice has influenced positive human resources educations and increased the sense of teamwork. So we are very thanks to SWOG of the organization for let us work together with them. Thank you very much.
Thank you, Dr. Cabrera, and again, congratulations for those numbers that were recognized by Dr. Blanqui on yesterday's plenary. Next, and very brief, since they just joined, they are the new kid on the blog, our colleagues from Uruguay, Dr. Mauricio Cuello. He's gonna have a very brief overview of the studies that they're interested in. He's a medical oncologist and professor at the Faculty of Medicine in Uruguay. Thank you. Well, I see a different name, so Dr. Lira, I'm sorry.
Yes, thank you for the introduction, but Ivan Lira will do the presentation.
No worries, no worries. We are a team, so no worries at all.
Dr. Lira, welcome.
It's my pleasure. So are you able to see my screen?
Yes.
Okay, fantastic. So let's start. So first of all, I would like to thank this opportunity. So let's move on because it's a short time. So just to start, for us, we have here in Uruguay a couple of sites, obviously under the umbrella of the Faculty of Medicine, but we do have the Hospital de Clínicas and also the National Cancer Institute here in Uruguay. Right now, we have 3 studies that we're working on. We have the teams, and right now we're working to get access to the physics quality control core requirements, but seems like everything's moving in the right direction. We do have access to the Phantom, so it's just a question of time. Regarding the other 2 studies, the S1714 and S2013, both were already submitted to the IRB. So hopefully we will get more information regarding this during the next few days. Regarding our team, our roster, well, we are a very young and very vibrant team, as you can see. Our PI is Dr. Mauricio Cuello, well known for most of you, but we do have many other team members. Our next steps right now, recently we received, as you know, the approval from the Department of State to be part and to join to other trials and to SWOG and NCI. So we are very excited about it because this is going to be the door that will let us participate more actively in other studies. So we will update the roster at the CTSU, and also we will integrate our group to different SWOG committees, which is one of the biggest ideas, and it's very important for us to get involved. Right now, we believe that it's important for us at least to join a few committees like symptom control, lung cancer, cancer care delivery, breast cancer immunotherapy, melanoma, and also GI as well. So far, we do have some contact and some interaction with other teams. Recently, this idea started back in Mexico when I was a resident there, but right now we are trying to push to our other frontiers, and right now we're trying to open this door through SWOG to get access to more data. Right now we touch base with Dr. Kim Margolin, and also we will touch base with Dr. Aung Naing. Sorry, it's a very complex name. I'm pretty sure this doctor is well known by you. Dr. Chavez is from MD Anderson. And we are trying to touch base with them because we are very, very interested in this study, immunotherapy prescription in Latin America. We would like to see and analyze a pharmacoeconomic point of view. Dr. Mauricio Cuello and myself, we are the PIs in this study. I will try to resume all this presentation, all the next slides, because of a question of time. But as you must know, well, immunotherapy is a very well.
Dr. Lira, I think we're going to present this one a little bit later when we discuss.
Oh,
okay.
Yes, so this will be part of the roundtable at the end, but this is perfect. Thank you.
Yeah, thank you.
All right, thank you.
Thank
Just
you.
in time.
Thank you. So next in our agenda, we have Dr. Bettina Mueller. He's an oncologist at the National Cancer Institute of Chile. And she's going to present briefly a project that she and her colleagues have been working on now for quite some time. Dr. Crowley has been instrumental providing feedback on the entire CRAB team. They've been in conversations with the GI committee, and we wanted to present, the last, kind of like shape, because maybe this could be one of those ideas that are starting in Latin America and that can hopefully maybe be of interest of SWOG. Dr. Mueller, thank you for joining us.
Well, thank you very much. So I will start sharing the presentation. Can you just give me feedback that you are seeing it?
Yeah, we're seeing it. We just need you to make it full screen. Perfect. Yeah. Perfect.
So thank you very much for the invitation to show an update of this trial. The proposed title for this is Surveillance and Early Treatment Upon Progression After Curative Surgery in Gastric Cancer Trial, or SETUP. And as you said, we have been working on this a time now. And it is myself with Alejandro Corvalán that we had been given this idea and discussing this idea with Latin American colleagues, and also with Dr. Crowley and many other people. So it's really exciting for me to show you this new updated version. So the research question is to evaluate if an intensive schedule for surveillance using ctDNA and imaging improves overall survival in gastric and gastroesophageal GE junction cancer patients treated with curative intent compared to clinical surveillance. We have other specific aims for this, including quality of life and financial toxicity. And the background for this is that as we knew, gastric cancer and GE junction cancers are one of the leading causes of cancer death in Latin America and also in the world. Many patients here present at a locally advanced stage, where recurrence after adequate surgery, even if multimodality treatment with chemotherapy or radiation is given, is a frequent event. Until today, no evidence for an intensive follow-up has been described, but the NCCN guidelines now recommend regular imaging in asymptomatic patients with a proposed schedule that ranges between a total of 7 to 13 visits during the first 5 years, with 7 to 9 CT scans to be done during this period, and the guidelines recognize the lack of data to support these recommendations. We also know that palliative chemotherapy improves survival for patients with recurrent or metastatic disease, but many patients present with poor performance status at the moment of recurrence or progressive disease and are not able to receive the treatments. And therefore, we hypothesize that early detection of recurrence could allow the administration of palliative chemotherapy when symptoms due to the progression are absent or mild. So on the other hand, we know that the liquid biopsy, for example, circulating DNA or RNA or microRNA, are widely studied for different clinical purposes, including gastric cancer, and for early detection. Alejandro Corvalán has been working on this issue, but also for response to therapy, diagnosis of residual diseases after surgery. In gastric cancer, we have some data about this. And we also can assess mutational status on recurrence. Cell-free DNA includes both coding and non-coding sequences, and we can determine characteristics like microsatellite instability or other aberrations in this cell-free DNA. Dr. Corvalán, Alejandro, studied the methylated cell-free DNA called Reprimo, and he observed that in a high percent of patients with gastric cancer, this CF cell-free DNA can be detected, and that there is a concordance with tumor burden and the level of detection. So this is the design, the updated design. The last time I presented it, it was 3 arms, but now I have taken the advice to do it a 2-arm study. The arm A would be a clinical surveillance, and the arm B would be the intensive surveillance with cell-free DNA and images. Given that the palliative chemotherapy would be given on discretion of the physician using the treatment decision protocol that would be standardized at each participating institution, this would be an observational, prospective, multi-center, and hopefully international trial. So these are the methods. The visits frequencies are standard in both arms, as following the NCC guidelines that state that visits should be done every 3 to 6 months for 1 to 2 years, and every 6 to 12 months for 3 to 5 years. And as you can see here, arm A would do the less intensive schedule, and arm B would be the more intensive schedule. The CT scans for arm A would be only on year 1 and 3. This was used in another follow-up trial for colorectal cancer, the Colorectal trial, and I thought that would be an interesting point to investigate. And arm B would use the NCCN intensive schedule for CT scans. And arm B would also include the ctDNA to be done in every clinical visit. Endoscopy would be done in arm B as clinically indicated, as stated in the NCCN guidelines, but arm B would be more intensive on a yearly basis. Eligibility would be quite broad. We could include patients as stated here, but we would limit it to locally advanced disease as to avoid testing people with less risk to recur as the stage 1 diseases. And obviously metastatic disease would be excluded for this trial. Feasibility, I think that won't be a problem, as gastric cancer is one of the leading causes of cancer death in Chile, Peru, and Colombia, oral SLAG members, but also GE junction cancers are rising in incidence in the Western world, and a similar trend actually is seen also in Latin American countries. There is a clinical equipoise, as there are no randomized data to guide us for surveillance in gastric and GE junction cancer patients. And there is evidence, or there are data about the utility of ctDNA, but it is not, we don't have randomized data to really include this in our clinical practice. The statistical considerations, I haven't done a new calculation, but with 3 arms, there had been 700 patients to be included, but this should be calculated again. Potential barriers are contamination through imaging or other studies that are ordered by other physicians, and it would be very important to have the input from patients and physicians about the acceptability of this design. So thank you very much, and I'm looking forward to hear your comments.
Thank you so much, Dr. Mueller. So as you guys can see, this is a proposal that has clearly been worked extensively. We will continue to work with Dr. Mueller and Dr. Crowley to do the final touches and get the GI committee involved. I know that this was a lot of work, and if there's anybody that has any brief comment, maybe we can make an exception for something very brief. Well, Dr. Mueller, thank you. We will continue to try to push this great idea forward and get it to the GI committee. So what we have done so far is really get, an overview of what's happening in Latin America. What are the barriers? What are the great achievements of our investigators down there? And what we want to do now is actually to present to our Latin American investigators a proposal from Dr. Lynn Henry. She's developing a proposal regarding breast cancer in young women in Latin America. So this is part of an R01. So Dr. Henry, thank you so much for joining us. We're excited about this potential project.
Thanks. Can you see my slide? Does it look the right way around or no?
Perfect.
Okay. So thank you so much. I'm Lynn Henry. I'm one of the breast medical oncologists at University of Michigan, and I've been working on this proposal with Dr. Don Hirschman. Let me figure out how to make them go forward. Sorry. There we go. So what this proposal is focused on is young women with breast cancer who are at high risk of disease recurrence. We know that this population has been studied in the SOFT and TEXT trials, and by adding ovarian function suppression, in addition to endocrine therapy, we are able to improve disease-free survival in this population. But that comes with a price, because it definitely increases toxicity and it worsens quality of life for these patients. And almost a quarter of women actually stopped taking their endocrine therapy early in the SOFT and TEXT trials, specifically the aromatase inhibitor therapy. And that was more common in women who were younger, meaning under the age of 35. We also know that there's been a lot of work in patient-reported outcomes. When you use them routinely in clinic, they have been shown to improve patient-provider communication as well as patient satisfaction. And there's a new concept of active symptom monitoring that you may have heard of. It's been demonstrated by Ethan Bosch and others, which is frequent assessment of patient symptoms, either in clinic or often even in between clinic visits. And so this has been shown to improve survival in patients with metastatic disease. And it's also been used extensively in early stage cancer, looking at acute chemotherapy toxicity, but it hasn't really been looked at in patients who are taking a more chronic drug such as endocrine therapy. So we are proposing that active symptom monitoring in this population of young women with breast cancer will increase persistence with endocrine therapy by both reducing toxicity and, more importantly, increasing patient-provider communication. So as part of the study, the primary endpoint is to investigate the impact of active symptom monitoring on persistence with endocrine therapy over 18 months. Secondarily, we want to look at the impact on symptoms, on patient-reported and objective measures of adherence, and then also build a risk model of non-persistence with endocrine therapy, so we can really try to identify up front which patients are more likely to be non-persistent, either because of symptoms or because of medication beliefs or other reasons, so that we can develop ways to target those patients up front rather than waiting for them to stop taking the medicine. So eligibility for this study is you have to be premenopausal at the time of diagnosis. You have to be planning to receive a treatment that will result in ovarian suppression or ablation. So that can be concurrent GnRH agonist therapy. That can be bilateral salpingo oophorectomy after the diagnosis of breast cancer, or that can be patients with chemotherapy-induced ovarian failure, as long as you're willing to monitor those patients closely to make sure their ovaries don't wake up again when they're on the endocrine therapy. And we're allowing a bit of a window. You can enroll up to 4 weeks before through 2 weeks after the initiation of endocrine therapy. For patients who are starting tamoxifen, they can't have had that before for treatment or prevention. Similarly, with AI therapy, you can't have had it before, except in the setting of fertility treatment. You have to have completed surgery indicated, and we're allowing concurrent therapy longer, at least in the United States. And patients must have some sort of access to the internet, either phone or computer or tablet, and have English or Spanish. So this is pretty straightforward. It is 2 arms. Half of the group will get patient education alone. Half of the group will get active symptom monitoring. Patient education are just some access that either describe symptom information or healthy lifestyle. Those are available in English and Spanish. And then patients will come into clinic every 3 mostly.
Dr. Henry, you're cutting out a little bit. Can you check and make sure your microphone's fully plugged in?
Sorry.
Thank you.
Oh, wait. Is that any better?
Yeah.
We won't know, will we?
It just cut out occasionally. I think it might have corrected the problem. Thank you.
Okay, we'll see. So patients will be seen every 3 months in clinic, at which time they will complete written patient reported outcome questionnaires. So the intervention, patients will complete 6 questions. If they're assigned to the intervention arm, they'll complete 6 questions on their device that are really just about severity of symptoms. So hot flashes, depression, anxiety, things like that. And then if they have a symptom that increases above a certain threshold or is either increases from the previous value over a certain threshold or is just absolutely over a certain threshold, then the clinic will be notified. But if they remain below that threshold, they'll just complete the questions every week for the first 6 months and then every 4 weeks. And it's pretty straightforward, pretty quick. If it's above the threshold, however, there's going to be a notification goes to the clinic, and then the clinic is going to be expected to reach out to the patient to say, hey, what's going on? Find out if there's a symptom that's really bothering them, do they need to do anything about it? And then document what they recommended. So importantly, symptom management is not directed by the protocol. The physician is allowed to do what they want to do. We're not saying you must fix a certain symptom in a certain way, although we will provide some guidance for sites that want it. There are some patient-reported outcomes looking at symptoms, looking at treatment satisfaction, looking at adherence, and also medication beliefs. And then there will be blood samples collected at 4 time points, partly to look at estradiol and partly to look at drug concentrations and metabolite as an objective measure of adherence. The primary endpoint is looking at the discontinuation of the initially prescribed endocrine therapy, which can be either aromatase inhibitor or tamoxifen. And importantly, in addition to not dictating what symptoms have to be, how symptoms have to be managed, we're also not dictating which endocrine therapy has to be used, what method of ovarian suppression has to be used, or anything about dose or schedule adjustment. So it's really letting doctors be doctors. The plan is for 540 patients. We're hoping to improve persistence by about 50%. This will be R01 funded, which should be funded based on the score. And it will be open to all NCTN and NCORE sites, including SLAI. And we know that You unfortunately see a lot of younger women with breast cancer, and we hope that this will be very appealing to you. And just in terms of timing, the grant hopefully will be funded in December, which means we would like to get this open by summer, but probably fall 2022. So thank you so much for your attention, and I invite any questions.
Truly an exceptional study, and as you said, something that for many of our sites in Latin America, I'm sure that will be of great interest. I apologize in all this like rushing through our agenda. One, I didn't formally introduce you to, I'm sorry, Dr. Henry. Thank you for doing that for me. We will clearly be in touch because I think there's going to be a lot of interest. I know in Mexico, there is an effort to try to get treatment to young patients. There's people specifically interested in this topic. So we could potentially even start working on getting the protocol to work on the translation. That's some of the messages that we're getting. So we will be in close contact. Thank you so much. So we now are going to move to a round table. We probably are going to run a little bit over time for about 10 minutes. I know that it's a Friday afternoon. Those of you that can stick with us, please do. Thank you. I think that's a part that will be very productive to allow for discussion. So what we really have prepared is very small presentations from investigators in Latin America with very broad and rough proposals, ideas that they have and that we will like from our leaders at SWOG, other investigators to give feedback on. So hopefully some of those ideas can continue to evolve into something that can be of relevance, not only for SLI, but for also SWOG. So first we have Dr. Roberto Estay from Chile. If you want to share your screen, he's going to discuss or present an idea regarding the use of metformin plus conventional neoadjuvant therapy in rectal cancer.
Yes, here I am. Thank you very much for the opportunity. I hope you are, that's okay. So I'm Roberto Estay. I am medical oncologist from Santiago de Chile, and our team project is called Metformin plus conventional neoadjuvant therapy in rectal cancer, a randomized clinical trial. These are our partners in Chile, Instituto Nacional del Cáncer, Hospital del Salvador, Universidad de Chile, and GOCHI. We have a multidisciplinary team in this project. So let's get with the background. We know that colorectal cancer is a very important disease in incidence and also in mortality in the world. In Chile also, we know that in Chile, 48% of our patients diagnosed with colon cancer survive after 5 years. And in recent trials, we know that many high-cost drugs stand out among the treatment strategies. So we have metformin, that is the most widely used anti-diabetic drug in the world, with a good safety profile. And in vitro evidence shows that it could have anti-neoplastic effects. In my MPH thesis, I have made a systematic review that conclude that there's a significant amount of evidence that suggests that maybe there are survival benefits if we associate metformin during the adjuvant treatment of colorectal cancer patients. In the study from 23 selected research, 50 show benefits in the outcome of overall survivor and other in disease-free survival. In many retrospective studies, that results suggest also a therapeutic role, like the one study from Coyle and collaborated. And recently, a new retrospective study in the setting of patients with rectal cancer suggests a notable effect on survival and in pathological response in the neoadjuvant setting. that is a very interesting setting for us. There's an ongoing trial adding metformin in the neoadjuvant treatment of the long radiotherapy associated with chemotherapy with capecitabine, but in the setting of the new standard therapy from the Rapido trial, that sequential radiotherapy and chemotherapy, we don't have any trials. Also, another study showed that the KRAS mutations seems to have a role here, and maybe these patients could have a better response to the therapy. There are also many molecular mechanisms that, because of the time, I will pass this, but we know that the mTOR pathway and the RAS pathway could have a role here, and that's very interesting for us also because of the biological basis. And our proposed protocol is this. Our research questions is if can metformin improve cancer outcomes in patients receiving neoadjuvant therapy based on short radiation therapy and consolidation chemotherapy? And if is there an association between the molecular subtypes of colorectal cancer with emphasis of KRAS mutations? Our specific aim one is the complete pathological response, the proportion of pathological response, and also the immunological response rate by MRI. The outcomes, we want to see the DFS time from local distant recurrence, the overall survival, and the quality of life. We also study another basic indicators, and we want to work in Chile, and we like to associate with other SWOG centers if that is possible. The criteria is locally advanced disease, and this is the flow of the trial, add metformin to the standard therapy or to and the other arm will be a placebo. What's the strength of this trial? The result can be evaluated in a relatively short times, 2 years. The intervention is cheap and safe, and the colorectal disease affects many people in the world, so this is an interesting strategy. We have some questions, that's all. Thank you very much.
Wonderful. Thank you so much, Dr. Estay. Next, we have our team, Dr. Arguello and Dr. Lira from Uruguay. Now it's the time, Dr. Lira, if you want to go to those slides where you were going to discuss your proposal on immunotherapy prescription, a pharmacoeconomic point of view.
Absolutely. So, okay, let's resume our presentation. So, this idea, as I said, started back in Mexico when I was resident. So we are trying to push hard to get it done and to get some support to make it like a good study. The title is Immunotherapy Prescription in Latin America. I think it's very important because we would like to address a pharmacoeconomic point of view. Dr. Mauricio Cuello and myself, we are the PIs of this study. So right now, as a background, it's important to recognize that the immunotherapy is a well-known treatment option for solid tumors. Right now, we know that melanoma lung cancer received initial approvals for IO. Nowadays, diverse approved indications are well known. Immunotherapy also is available in Uruguay and Latin American countries. High cost is an important barrier. We must recognize and remember that pembrolizumab started with 2 milligrams per kilogram Q3 weeks and nivolumab 2 milligrams per kilogram Q2 weeks when they were approved based on PK studies and phase 2 and phase 3 studies. However, fixed doses right now are the ones that are well recognized with 200 milligrams Q3 weeks and 240 milligrams Q3 weeks respectively were introduced and right now are well approved by the FDA, and most of the new clinical studies are recommending these doses for every single trial. Despite different dose regimens using either patient's weight, fixed or weight-based up to a maximum dose, fixed dose is the most common prescription partner and the one recognized or recommended by FDA. Right now, the kilogram-based dose is mostly approved for young patients, like children patients. Fixed or flat prescription partners has diverse blind spots that may increase economic toxicity in limited healthcare systems like ours. Latin American phenotype is unique. We all know that is unique, and flat dose may correlate with previous international studies where overdose is directly related with increasing costs and reduced access to more patients. How it all described a $1.4 million saving exploring weight-based doses of pembrolizumab and nivolumab in a 4-month study period. In Mexico, we do have some experience published back in the Lung Cancer Congress back in 2019 by Dr. Macedo Pérez and myself, and we showed that up to 1/3 of annual cost with immunotherapy like pembrolizumab and nivolumab is related to overdose. We found a mean weight of 65 kilograms in our population.
1 minute remaining.
Therefore, we are trying to describe the economic impact of a kilogram-based prescription versus fixed dose in Latin American population. Right now, we are trying to find the best way to get it done. We explored this study with the IO team, SWOG team, and they said that probably makes sense just to try to get a retrospective study. Also, we had some feedback from Dr. Grallo when she was part of the team, SWOG team, and she said that probably a prospective study. However, it's difficult for us to find the best way to get it done because, well, which pharmaceutical company will find useful to find another way to prescribe these kind of medications? Options. Right now, we are trying to move toward the S2013 because this study is trying to find immune checkpoint inhibitor toxicities in a prospective observational study. Therefore, maybe we can try to find a way to attach our idea to this trial. So that's why I'm trying to touch base with Dr. Aung Naing from MD Anderson, as I said before, as a recommendation from Dr. Kim Margolin from the SWOG IO committee, trying to find the best way to try to touch base with this other team. Thank you.
Wonderful, thank you. And we can probably discuss about ways, but Dr. Hirschman, who's the co-chair of the Cancer Care Delivery Committee, commented exactly that in the chat box. We next have our team members from Colombia. It's going to be la doctora Silvia Guerrero, who's going to present a proposal on cytoreductive surgery and hyperthermic intraperitoneal chemotherapy versus palliative systemic chemo in patients with gastric cancer that have peritoneal carcinomatosis. Dr. Guerrero, thank you so much for joining us.
Good afternoon. Thank you to everyone. My name is Silvia Guerrero. I am representing the group of peritoneal malignancies of the Instituto Nacional de Cancerología, Colombia. This is the name of our project, cytoreductive surgery and hyperthermic intraperitoneal chemotherapy plus systemic chemotherapy versus palliative systemic chemotherapy in gastric cancer patients with peritoneal carcinomatosis. Our principal investigator is the Dr. Mauricio Garcia Mora, surgical oncologist of our institution. A little of background, we know that peritoneal metastases are present in gastric cancer patients in about 16 to 30% of the cases and 16% at the time of the diagnosis. Cytoreductive surgery and hyperthermic intraperitoneal chemotherapy have been improved the overall survival of these patients 2.2 to 8 months to 11 to 22 months for these patients. There are several publications to support the use of this therapy. However, there is no strong evidence that in clinical trials they allow the adoption of this therapeutic approach as a new standard of treatment of these patients. The aim of this study is to clarify this question, and for this we propose this clinical trial. Our group in the Instituto Nacional de Cancerología is active since January of 2013. We have 2 trained surgeons, clinical oncologists, anesthesiologists, critical care, rehab, nutrition, psychology. We have 1 weekly tumor board meeting, and we discuss 1 or 2 cases per week. Today, our group has performed about 250 surgeries in patients with pseudomyxoma, colon cancer, ovarian cancer, mesothelioma, gastric cancer. 3 gastric cancer patients have undergone surgery this year. Our research question is, what is the efficacy and safety of complete cytoreductive surgery plus hyperthermic intraperitoneal chemotherapy plus systemic chemotherapy in comparison to systemic chemotherapy alone in patients with peritoneal carcinomatosis of gastric origin? The principal study objective for this study is assess the efficacy and safety of cytoreductive surgery plus HIPEC plus systemic chemotherapy versus standard chemotherapy in patients with peritoneal carcinomatosis of gastric origin. Some specific objectives of this study: estimate overall survival, progression-free survival in each treatment group, also compare the efficacy and safety outcomes between treatment groups, compare the efficacy and safety outcomes between the treatment groups according to PCI score, and report the quality of lives and rates of abandonment of systemic therapy secondary to adverse events in each treatment group. Our study populations are patients older than 18 years old with gastric cancer, confirmed by histopathology study, presented with peritoneal carcinomatosis in the staging process, and up to 6 months after the initial diagnosis with a PCI less than 12, confirmed by laparoscopy or laparotomy. Our study endpoints, the primary is overall survival, mean overall survival, and to 1 and 3 years. The secondary are efficacy outcomes, safety outcomes, and patient-reported outcomes like progression-free survival, local progression-free survival, distant progression-free survival, perioperative mortality to 30 days, toxicity, and postoperative complications measured by Clavin-Dindo to 30 days, quality of life, and treatment abandonment rate.
30 seconds remaining.
Sorry, this is our flow chart. Patients with confirmed gastric cancer with peritoneal carcinomatosis, confirmed by laparoscopy, PCI less than 12, who have completed 3 or 4 cycles of platinum-based doublet or triplet chemotherapy. The patient goes to abdominal CT or MRI for document progression. If the patient has progression, the patient is excluded for this study. If there is no progression, the patient goes to randomization to the standard treatment group or the experimental treatment group. In the experimental treatment group, the patient goes to cytoreductive surgery, followed by platinum-based doublet or triplet chemotherapy, and followed by chemotherapy maintenance and support measures. Our inclusion criteria: patients with more than 18 years old, biopsy-proven primary gastric adenocarcinoma, HER2 positive or negative, sign chronic peritoneal carcinomatosis, PCI less than 12, or positive peritoneal cytology confirmed by laparoscopy or laparotomy, and proven by pathological examination. Complete perioperative treatment with systemic platinum-based chemotherapy, 3 or 4 cycles, and with the last cycle ending no more than 8 weeks before inclusion. Absence of disease progression during systemic therapy prior to inclusion, and ECOG less than 1, and normal post-chemotherapy stress echocardiogram. And this is our exclusion criteria: distant metastases.
Do you mind wrapping up? We're done with your allotted time. If you just want to wrap up.
Sorry. Okay. We discussed this before with our biostatistics, and this is the the sample size calculation, 120 to 134 patients for both arms. We have expected recruitment for sites is 6 to 8 patients per year. If maybe we have more than one site, maybe 10 sites, we have a total of 60 to 80 patients per year. And maybe with assume the accurate rate is 60 patients per year, we have to obtain the accurate period of 2.2 years, that is 26 months.
So clearly, we hopefully will have time, sorry to interrupt, issues regarding feasibility at the end of the table discussion, as you know, we might need to have large numbers of patients. So in order to discuss that with the rest of the members of the people on the call, we're just going to go ahead with the last presentation from the roundtable from Dr. Sergio Aguilar from Mexico. He is a breast medical oncologist, and he's going to present an idea that they're working on the use of aromatase inhibitors as neoadjuvant endocrine therapy in premenopausal patients. So Dr. Aguilar.
Thank you, Dr. Chavez.
Dr. Guerrero, we need you to stop sharing your screen, please.
Yes.
I don't know, Dr. Aguilar, if you can click share, maybe
I cannot share it because someone's still sharing it. That's my impression. Let me see.
I stopped the sharing. I don't know.
Perfect.
Done.
Thank you.
Well, good afternoon. My name is Sergio Aguilar. I'm a surgical oncologist at the NCI Mexico City. Our protocol is titled Aromatase Inhibitor-Based Neoadjuvant Endocrine Therapy and Objective Response Rate in Premenopausal Women with HR-positive, HER2-negative breast cancer, called NEAREST. Principal investigators, it's me, Dr. Vargallo, and Dr. Cabrera. And the research question is aromatase inhibitor-based neoadjuvant endocrine therapy non-inferior to chemotherapy in achieving objective response rates on premenopausal women with early stage HR-positive, HER2-negative breast cancer? Our first aim, our specific aim one, is to determine if aromatase inhibitor-based neoadjuvant endocrine therapy is non-inferior to chemotherapy in achieving objective response rates on premenopausal women with early stage HR-positive, HER2-negative breast cancer. Our specific aim number two is to compare the number of patients considered initially for mastectomy that are taken to breast-conserving surgery after treatment in both groups. The background is, well, we know that neoadjuvant endocrine therapy is an increasing therapeutic modality for this type of breast cancer, specifically in postmenopausal women. However, almost half of the patients with breast cancers in our country and in Latin America are pre or at least perimenopausal. The only randomized control trial comparing the objective response rates of neoadjuvant endocrine therapy versus chemotherapy in premenopausal women used tamoxifen-based NAP. And there's plenty of evidence that aromatase inhibitors achieve better response rates than tamoxifen in both pre- and postmenopausal women. So, giving a little bit of the rationale, the trials that we have is a GACAM in 2006, which was an exploratory analysis in which you had a better response rate using chemotherapy in premenopausal women, but we have a very small number of sample. Then the NEST trial, which is the trial that changed or that derived what the rules are right now. However, they used tamoxifen and goserelin. And another important thing is that they had an enrollment failure and their measurement was with MRI. Even the authors mentioning at their discussion that it's perhaps not the best way to achieve or to measure this. And finally, we have the STAGE protocol, which compared the tamoxifen and goserelin regimen versus the anastrozole and goserelin. And of course, we see a better response rate, objective response rate of 70.4% by caliper, 58.2% by ultrasound. So now our data source, we're going to have to do a phase 3 randomized non-inferiority control trial with premenopausal patients at the National Cancer Institute in collaboration with other Latin American centers. The patients have to have an invasive breast ductal lobular or ductal carcinoma T1, T2, and 0 up to N2A, and estrogen receptor expression with an L-rate of 6 minimum or more. Progesterone receptors as well have to be all with an L-rate of 6, and the key 67 expression will be of 20% or less. This might be due to discussion, but we're choosing this. They have to be HER2 negative and grade 1 to grade 2. The proposed methods are that patients in the control group would receive standard chemotherapy based on anthracyclines and taxanes based for 6 months, and patients in the experimental arm will receive AI plus goserelin 3.6 milligrams subcutaneously each 4 weeks for 6 months. Now, both groups will have a baseline clinical evaluation by caliper, mammography, and ultrasound, and then every 4 weeks, clinical evaluation by caliper. Every 8 weeks, then, evaluation by ultrasound, and a final measurement with the 3 methods before surgery. The objective response rate would be the sum of the 2 longest diameters of the lesion by any imaging method or by caliper, and after any given treatment. Now, if we would have a fragmented response, that this could happen in these patients, we would take into account the sum of the 2 longest diameters of the predominant lesion. Now, considering a non-inferiority margin of 10%, a preliminary estimate for the sample size to have 80% of power is 400 patients in total, and to have a 90% of power, there would be 536 patients. Now, the proposed protocol is somehow like this. We have our groups, our experimental group and our control group. They will both receive the standard treatment or the experimental treatment, and afterwards we're going to give, if estradiol is completely over or up at 4 weeks, then we're going to give goserelin. And
1 minute remaining.
And if estradiol is still not at what we would like to have, which is less than 20 picograms per milliliter 4 weeks, patients are going to chemotherapy. If patients after goserelin have estradiol less than 20 picograms, they will go then to goserelin and AI at 2 weeks. At 2 weeks, we're going to take a biopsy to see if the Ki-67 is less than 10%. And then afterwards, the patients are going to receive goserelin plus the aromatase inhibitor each 4 weeks for 6 to 8 months. This will be measured, as I already mentioned, with ultrasound and clinical measurement by caliper every 8 weeks, and until we have the final preoperative ultrasound or clinical measure by caliper. If patients after goserelin and aromatase inhibitors have a biopsy at 2 weeks, more than 10%, we'll have to consider them to go to the chemotherapy arm due to progression concerns. Afterwards, all patients are going to go to surgery. However, our final or primary objective is going to be the final preoperative ultrasound and this clinical measurement by caliper. The next steps describe the clinical, pathologic, and radiologic characteristics in both groups. We're going to analyze change in Ki-67 after the net, less or more than 10%. We're going to identify the number of patients with PEPI score of 0 after surgery, and we're going to compare the actual or complete response burden, comparing NAC versus NET in both groups. And this trial is designed to be ideal in multicentric and multinational. Thank you.
Thank you so much to all our presenters. And now really we can open it to questions, not to really pick on anybody here, but we have the privilege to have Dr. Don Hirschman and Dr. Ling, who already commented on the proposal from your way and the possibilities to join efforts with S2013. Dr. Bill Barlow and Dr. Pusa from the Breast Committee are on the call. I don't know if anybody wants to start with any comments, suggestions, directions, next steps.
So maybe I could, if I could ask you that, what would be the importance of showing that, let's say, the clinical objective response rate is similar with endocrine therapy versus chemotherapy in the neoadjuvant setting?
Yeah, thank you for your question, Doctor. This would be considering toxicity and that there might be a group of patients that might benefit from this therapy. And afterwards, if we don't have the ideal for example, nodal response, or if we don't have a response for this, they could be considered to give adjuvant chemotherapy in either way. But initially it would be toxicity and perhaps choosing a group of patients that might benefit from this therapy in order to have less extensive surgeries in principle.
So Sergio, I know that you've been working on this idea with Paula, but as a breast medical oncologist, I will say that in patients with node positive disease that are premenopausal, like clearly the standard of care is chemotherapy. So were you guys thinking of giving everybody chemo in the adjuvant setting that were randomized to neoadjuvant endocrine therapy? Because that maybe Lajos' question goes that, like, why do we need to look into this?
Yeah, well, perhaps because of the response might be better, and they might have a complete nodal response. But definitely, I mean, the objective of this trial is initially to finally decide or to demonstrate that either chemotherapy is better in the neoadjuvant setting against neoadjuvant endocrine therapy, because we haven't used yet the standard that would be a aromatase inhibitor. But yeah, totally. I mean, if the patient has or have a positive node disease, they should go to chemotherapy. I mean,
have you thought about sort of trying to get to this address just by looking at results from the many neoadjuvant trials that have been published or done? So, all of the neoadjuvant chemotherapy studies include premenopausal women. And so you could really get from the literature the actual objective response rates and the pathological response rates and nodal eradication rate. And there is also a very large number of neoadjuvant endocrine trials that have used aromatase inhibitors with or without CDK4/6 inhibitors, mostly in postmenopausal women, but also a fair number of premenopausal women who had ovarian suppression. So, I mean, it might be worth actually looking these results up because that's available in the literature.
Yes, doctor. Thank you for your, as I was saying before, it is in literature. However, the trials that have these patients included are not powered enough to give it as a complete, as a non-inferior or inferior treatment. Well, the only trial being this NEST trial, this made in South Korea, but using tamoxifen, not having their enrollment complete, and using MRI for measuring. So that's like the way to justify. I mean, I know there is a lot of information of this therapy in the literature. However, as in numbers and as into designing a clinical trial with the best treatment possible, we don't have it yet because we haven't used aromatase inhibitors comparing aromatase inhibitors in Gosserlin comparing with chemo. That would be my point.
And I think Dr. Hirschman has her hand raised.
Yeah, I'm just in I-SPY, which is a large neoadjuvant trial. They have an endocrine optimization arm that is including a variety of different strategies in the neoadjuvant setting for patients that are mammoprint low risk, so people that may not particularly benefit from chemotherapy. And some of it is looking at the new oral thirds or new oral thirds in combination with CDK4/6 inhibitors. So it might be a good idea to look at what that pathologic complete response rate is with the most modern endocrine approach, and think about that in terms of versus chemotherapy in that low risk population to help guide a study like this.
Yeah, thank you, Dr. Hirschman. And precisely that's the reason. I mean, initially to give that leap of avoiding chemotherapy in this specific group of patients which have low risk for recurrence, even perhaps if they have initial node disease and afterwards they have a PEPI score of 0. That's the reason of having the PEPI scores afterwards. The first thing that would have to be proved is that it is non-inferior in the matter of a tumor volume, because according to the guidelines, the ASCO guidelines, they're not recommending neoadjuvant endocrine therapy because of this NEST protocol, because their objective was to determine if it was non-inferior, and it was inferior, but they used tamoxifen with the other methodological trouble I mentioned before. But yes, totally.
Now, since we just had Dr. Hirschman unmuting herself a second ago, Dawn, hate to put you in the spot, but any thoughts as one of the PIs of 2013 in terms of, potential next steps or whether this could be an area of interest?
Yeah, I mean, I'll have Lynn join in as well. I mean, I think that, we definitely, sometimes these large, 2,000 patients prospective study. I think sometimes these large, prospective studies, it is a good opportunity for like thinking of sub-studies or other things that can be done. It's always hard to add a lot of data collection, but it's quite possible that some of this could be done, with modeling. And, if sites are opening 2013 in, Latin America, just to compare the different toxicities and then model some of the financial issues after the fact. But, you know, don't hesitate to reach out to anybody in the team so that we can at least brainstorm about what the best approach might be.
Thank you. So we also got some comments from Dr. Krause in the chat for the investigators in Colombia on their cytoreductive project. I don't know if anybody has any comments for Dr. Stay on the metformin trial for patients with rectal cancer. So I know it's almost 5 o'clock. We already went over time for 15 minutes. Thank you so much for sticking with us. As you all can see, there's great talent and ideas, and all these ideas take time to be developed. So for all of you presenting and thinking about these proposals, the idea is to shape them into something that it's doable and feasible and interesting. So thank you to the presenters. Thank you to all of those of you in SWOG leadership, people, chairing committees for joining us. We appreciate it at a personal level. Clearly, Dasha has been extraordinary and all the team at operations. And as I embark in this new role, I will need the help of all of you. So if you guys have any ideas, suggestions, feedback on this symposium for us to, you know, keep doing better. Dr. Crowley has been just extraordinary. I don't know if you want to close us with any words of wisdom and inspiration. You have been pioneer in this and you have seen this SLI initiative, you know, grow and born and develop. So thank you, everybody. Dr. Crowley.
Yeah, thanks. I'm so pleased with you, Mariana, and with all the great input from the investigators across the region. I must say that for the first time in a while, I see some green shoots of sustainability. So thanks to everyone for participating.
Well, thank you, everybody. Have a great weekend. Hope you had a great SWOG, and we'll see you in person in Seattle in the spring. Thank you.
Bye-bye.
Adiós todos.
Bye-bye.
Saludos, Kurt.
Hola.
Adiós, Javier.
Bye.
Bye, everyone.
Thank you. Welcome, Brazil.